Now we're going to talk about cerebral palsy, or CP. So the definition of cerebral palsy is that it's a range of nonspecific clinical symptoms that are characterized by an abnormal motor pattern of movement and postures. And this is caused by non-progressive, meaning it never gets worse, abnormal brain function. CP is the most common movement disorder of childhood, and it is 2 out of every 1,000 live births is affected. That's a lot. These are some of the risk factors. Being born premature, being born at a very low birth weight, having anything that causes hypoxia, any maternal fevers, seizures, or bleeding during the perinatal period, being exposed either in utero or shortly thereafter to radiation or environmental toxins. We also see genetic anomalies playing a big factor in this. Metabolic disorders can also cause certain levels of cerebral palsy. And maternal or fetal exposure to cytomegalovirus or toxoplasmosis has been known to increase the risk. And then postnatally, anything that impedes blood flow or oxygen flow to the brain can lead to cerebral palsy type movement disorders. For instance, one of my foster children was born normal and then suffered a non-accidental trauma to the brain and subsequent respiratory failure, and now has mannerisms and plegias and movement disorder that all looks very similar to a child who is born with cerebral palsy. We can also see cerebral palsy happening in children who have near drowning events and car accidents and tumors. So there's a couple different types of cerebral palsy. There's spastic, which is the most common form. Dyskinetic or athetoid type. We see this, the infant is usually born, they're quite limp. They have uncontrolled, kind of slow, worm-like twisting movements that almost looks like dancing. It affects all 4 extremities, possibly involves the face, neck, and tongue. And then these movements are increased and worsened during periods of stress. And then there is also what's called let me see if I can get it to open, ataxic type. So I don't know if you've heard of the phrase ataxic gait. It basically is saying that there's a lack of control, some hypertonicity. Some of the cues that we're going to see are spasticity, muscle weakness, ataxia, difficulty coordinating voluntary movements like walking, running, fine motor skills as well, like picking up objects. And then in the management of this, we try to get multiple specialties on board, including neurology, orthopedic surgeons, PT and OT, speech therapy, dietitians, psychologists. And as you can see, there's no standard treatment. The focus is really on us making sure that a person with cerebral palsy no matter what the range is, because it can range from so minimal that all you might see is that they maybe have a little contracture or hypertonicity of one hand, or maybe a limp, maybe something about their speech pattern is different, all the way to a completely nonverbal bedbound person who is incapable of providing any care for themselves. So our focus is on optimal development neurologically and optimal function as far as their bones and muscles are concerned. And we want to make sure that we provide preventative, symptomatic, and supportive care. And we need to make sure that they're going to have counseling, that they have counseling not just for their emotional state, but also in school, their counselor needs to be on board with what's going on, how to make sure that they are getting an appropriate education and that they are performing to the highest level that they can. And that also is going to involve the teachers. Most of the time, people think that a person with cerebral palsy needs to be in some sort of special education, but cerebral palsy is not necessarily a neurologic disorder as much as it is a motor neuron disorder and movement disorder. So frequently, even the child that is bedbound and nonverbal, they don't really have any difficulty understanding things like language or facial expression or nuance. They're very intelligent people. They just are kind of stuck, trapped in that non-functioning body. So please remember that all of your patients who have cerebral palsy need to be treated as such, that they are normal human beings aside from having a movement disorder. So these are some of the interventions that we can help to bring as nurses. We want to promote mobility, promote good nutrition, because frequently patients with cerebral palsy have swallowing difficulties, and we want to give ongoing support and education to families. So we want to get PT and OT involved because they're going to be the ones who really help with the day-to-day movements of these patients, providing them with assistive devices, mobility aids, bracing, and splinting. Splinting can be used for a lot of these patients because a hypertonicity of the, let's say, the foot or the ankle or wrist, if you flex your hand towards the midline and keep it like that for really long periods of time, the musculature itself, the fibers are going to shorten over time, and this will lead to actual contractures. So frequently what we see in the hospital setting that we think are contractures are really just muscle spasms that's causing an abnormal posturing. If you can straighten a hand out or straighten out a leg, it is not a contracture. A contracture is actually at the bony level, and the muscle fibers have completely shortened at that point. You would not be able to extend it. So check that. And then if you're able to extend it on your patient, then maybe get PT and OT on board so that they can give that patient some splinting or bracing to use to reduce the shortening. We can also use things like botulinum toxins. So Botox can be injected directly into the musculature, or even baclofen, dantrolene, or diazepam. All of those can be utilized to reduce the spasticity of the musculature. So so that they can walk without as much jerking or rigidity in their movements. Some patients need anticholinergic medications to decrease the amount of abnormal movements they might have. We also find that drooling and increased salivation is something that most patients with cerebral palsy experience quite a lot of. So they will take scopolamine, which can be used, like you put the little thing behind your ear. It's a scopolamine patch, and it's used to keep you from being seasick or nauseous. Those are anticholinergics. So we can use scopolamine or glycopyrrolate to decrease the salivary response and control the drooling. Because in a patient, let's say that they're bedbound and they have a constant drool, that's going to lead to skin breakdown, increased infections, dental problems like cavities, and also for somebody who's just out in the world, they really don't want to be drooling all over the place, because that's just another thing for society at large to hold against them. So we will give those medications to try to decrease it. Something that's also very popular is implanted baclofen pumps, because in order for baclofen to really slow down the muscle spasticity, it needs to be at a constant level. So having an implanted pump is very good for the patient who is just having problems with spasticity interfering with their day-to-day life. And then these are some of the complications of cerebral palsy. They can obviously have some mental impairment. They can have seizures. They can have problems with growth overall, and visual or auditory problems. And frequently there can be some level of hydrocephalus involved as well. So some cerebral palsy patients will need to have VP shunts in place to control